I just sent you the link, Tracy.
Okay, waiting on it to come through. Okay, it's posted. Let me go verify it's working. Okay, you're good to go.
Want to call the meeting to order, the Polysomnography Advisory Committee. Please know any comments by the public are welcome and can be emailed to public comment at lsbme.la.gov. Please confirm you verify the identity of all tele and video conference participants. If the sound is clear and audible to the public and those on the tele and video conference. All additions to the executive or public agenda must be made presently, as we will no longer be able to make additions to the agenda once in the public session. Next, roll call. I'm Dr. Joseph Bordelon.
Judson Willard.
Lauren Davis.
Kyle Schwab.
First item on the agenda is the kind of review of the rules update, the fiscal questions, and discussion of home sleep studies.
Okay, guys, I just want to let y'all know that the rules are slated to be published in the August Register. But the Legislative Fiscal Office did come back with two little questions that I wanted to just, clarify with y'all before we go forward. The first one, let me see if I can share my screen real quick. The first one he brought up just the direct supervision and then also direction and supervision of a physician. He just noted that it's like kind of confusing, if you're just like a layperson reading it, because it sounds like the same thing, but it's obviously different. And so I just told him, I was like, yeah, that's just the language that the committee uses, and that's how it works. And so like we're fine keeping it this way. But he had just raised it. So as long as everybody's fine keeping it, we can keep it going forward. But I didn't know if there's like another way to phrase it, if y'all think that that would be helpful to clarify or what. But it was just something that he raised, the guy at the fiscal office.
I think it encompasses the requirements that we need to see.
I think he meant more of like the direction and supervision of a physician versus direct supervision, because I think direct supervision is, of the healthcare provider. The way I explained it, it was kind of like direct supervision of the, placing the electrodes or and that sort of stuff, and on the actual testing versus someone being under the direction and supervision of a physician. So there is a clear distinction.
Yeah, there's a direct supervision means a physician would be physically present, not remotely present.
Right. And then the other little thing that he noted is he just wanted to see what the significance was of adding the collaborative practice physician. And so I just want to that it wasn't in the initial rule, and that's just there to capture, that sort of relationship as it might work. And so those were the only two things that he had questions about. And he said, if y'all are good with everything, then and we don't have to revise this further, then it should be published in August. Because adding the collaborative practice position, that is just to clarify that they're under this, right?
Correct.
Cool. Alrighty, well then, he said that he's going to be working to get everything approved, and then we can move forward with it.
Okay. Well, okay. Any other discussion on the home sleep studies and
I wanted to bring this up. I think that we're taking steps in the right direction. I agree with what we've got in there. I came back from the sleep conference in Houston recently, and I couldn't find anyone that from any other state that didn't allow home sleep tests to be mailed. I know this is something we want to be careful with, but for example, we've got Snap Diagnostics, they mail them. Watchpad has an IDTF, they're mailing them. We've got some other companies in Louisiana, and we don't really have any rules around them being mailed other than to say that it's not supposed to happen, but it's probably thousands of them every month. And it's not really anything we can enforce. So in my opinion, and we don't have to discuss this today, but I think we need to consider having some rules around the mailing, but allowing some to be mailed. For example, I had a guy here the other day who was from 2 hours away. Our sleep tech that provides the equipment wasn't here. We didn't have anyone that could give him the equipment. And I could have ordered a mail out test to him, but I didn't want to do it because it's not currently allowed.
In your street to try to get over. Like, you're just gonna have to get over. Like, quit being a pussy.
Wait, what was all that?
Sorry, my wife is trying to get out for
Judson. All right. Well, so anyway, in a nutshell, this example, the guy wasn't able to get his test that day. He lives 2 hours away. And as it stands, he has to come back, get the equipment, drive home, put it on, and drive it back to me. And I just think that it's impractical to 100% of the time not allow any of these mail out devices when they're read by a board certified sleep physician. They're followed up by me. I haven't done it, but it seems to me that we need to consider it. At least if you've got a sleep physician reading it and following them up, that's a different situation than we're just mailing them all over the place, to me.
Yeah, I think it's definitely a process where we have to start thinking about it, or probably should have maybe done this a while ago. I'm having the same instances. I have somebody with Down syndrome that can only wear one of those ring setups, and we don't provide those. Nobody locally has them, and so you do have instances where you have to use something outside or outside the box. I think, Kyle, you and I have talked about how do you ensure that somebody that's boarded in sleep follows up to see, was it an adequate study? Does it apply clinically, and where you go with it? Do we have any way to enforce that even? I'm not sure what our options are, to make sure that these are just not the same as wearables.
Yeah. One option might be, for now, we could have it, at least it's allowed if it's a sleep physician that orders the tests and follows them up. So even if we don't enforce all the other or anything, at least if you or I want to order it on your Down syndrome patient or my patient from 2 hours away, we're not feeling like we're breaking a rule.
Yeah.
Is this something we want to be adding into the rules now? Because if this is if y'all want an actual rule change on it, today's kind of the make or break moment on it, because we can whip something up real quick. But then we would delay it.
Do it, yes.
I mean, I
thought we were just trying to keep people from out of the state from mailing it in because they don't have a license in the state of Louisiana. Because I know that people are mailing them right now. Watchpad, I know for a fact. We don't use Watchpad, but I know people that do, and I know people that mail them in the state of Louisiana right now. 100%.
Yeah, no one's following. No, I shouldn't say no one. I'm following the rules, but most people are not. And it's putting some of the patients in a bind at times when they don't live close by. So at least I think in this rule, we'd like to allow us as sleep physicians to order tests that are mailed to the patient if we're following them up. I'd like to see something like that if possible.
Where would we put that wording?
It's a good question. Let's see.
So right now, what it says is licensed physicians, this has to do with that they should be licensed in the state of Louisiana, have a mechanism in place to ensure that patients receive the results of the testing with appropriate counseling regarding treatment options and follow up within a reasonable time frame from the completion of the test.
So we probably need to delete something from the area of having somebody in the direct, the last part that they didn't like, the direct versus indirect supervision. In there, I think that's the area where we say that somebody's got to be in the area that's boarded or licensed when they're set up on a home test.
Right. So supervision by a physician, polysom tech, registered respiratory therapist with an SDS who is currently licensed by the board. Supervising entity must be present in the area where the procedure or service is being performed and be available to furnish assistance and direction throughout the procedure or as needed.
So I don't know if we leave that and we add an addendum. The only other thing would be is if it's ordered by a board certified sleep physician and followed up by the board certified sleep physician.
I think we add, like you said, just a separate little comment that mail out tests are allowed if it's ordered by a board certified sleep physician and followed up by them.
Do you want that to be a licensed Louisiana board certified physician or any place from anywhere in the country? Because then what's going to happen is the telemedicine guy in Ohio may or may not follow up about how do you want to handle that.
We could say
you gotta
licensed
continue.
in Louisiana, I think.
Yeah.
Yeah.
Because
So
if they
would that-
want to do telemedicine in the state, they can get a Louisiana license.
Absolutely.
I do.
Exactly.
So,
So is that on direct supervision? Do y'all want this?
I think it's going to be further down, huh?
Yeah.
So this NOI, just the notice of intent, just has, it's not the full rules because I've taken out everything that we didn't change. If we add this, Patricia, correct me if I'm wrong, is this gonna have to go back to the board for approval?
It is a new rule that we do not currently have. So yes, I would believe that the board would want to weigh in on it and promulgate it as a new rule. If it's a clarification of an existing rule and we're just trying to explain what we meant all along, you could probably amend it from where you are and just be prepared to address the necessity for the Louisiana license or telemedicine license. I mean, the telemedicine license isn't in the area, so
Yeah.
you have to reconcile that, and then you have to worry about. I believe that you can justify it from a public safety standpoint, but you have to be prepared to justify it once the AG looks at it from an antitrust standpoint.
I was thinking that too, just because if you're okay with everything being telemedicine, including the shipment, you're never actually gonna have to see the patient. You know, is it protectionist to just require only Louisiana people to be able to do that and not allow someone from, Oklahoma?
Well, it's as long as you have a license in Louisiana, I would think. So we want them licensed here, but I don't think we should require every telemedicine visit to be done by a doctor that's physically in Louisiana, like Dr. Bordelon, who might not be in Louisiana and want to be able to do it. Or if I move one day, we don't have that many board certified sleep doctors in the state. So I think we
I don't
want
think
to.
I don't think you can limit it to just board certified sleep docs.
As far as mailing,
I think if you're talking about ordering home studies,
Because wasn't that the issue that we were trying to address in the first place, that we didn't want these out of state people to just do it and then not have a follow-up?
It was not only that, but it was also, they weren't getting good instructions, they were getting bad studies. Turns out the studies had to be repeated at a cost to the, sometimes to the patient, because the insurance wouldn't pay for a second one. And so we wanted licensed techs to be able to tell them what to do and that kind of stuff. But again, it's really up to y'all.
I think what we're trying to accomplish is to have a physician oversee the process, but allow some patients to have the equipment mailed to them so that we're not handcuffing ourselves, but we're also not making it completely wild, wild west. So I don't know how to word that, but something about a physician or board certified sleep physician
We have,
reading the test and overseeing their care, something like that.
So if I remember correctly, the two things we were trying to eliminate is people from out of state mailing stuff in without a license and doing everything. And secondly, there were people that were doing it that had zero connection with sleep. You had no one in any form of the process. The patient never saw someone that was a sleep person in any way. So that's what we were trying to eliminate. As far as mailing in-house, your examples are perfect. Like, especially, you know, a lot of these rural places, all their patients are an hour plus away. You know, there's, you know, because they're an hour plus from anything. They just live in the middle of nowhere. And so I don't think we should take away mailing, but we just want them to make sure we want to take care of the patient. So we don't want somebody that has no idea what they're doing and saying, hey, we'll mail this, and then some other doctor from over here will read it and send it to us, and then we'll tell you what to do, but really they have no supervision whatsoever. That's what we're trying to eliminate.
Do these new rules take away the ability to mail it? Because the changes that we made, we broadened it from
I
just
think that might
sleep
work.
docs to allow for like cardiologists and people to be able to order it. So now it's just a licensed physician that we've taken out like that clarification. And then we just said that you need to have follow-up and testing if you're billing for it and you're a licensed physician. So none of the changes that we've made have restricted it. Is there already a restriction in place that says you can't mail them that y'all want to get rid of? If not, we can kind of just move forward with this and see how it kind of shakes out and then make a revision later on.
Well, I think somewhere in there, the way I understood it was the actual handing of the equipment to the patient had to be done under direct supervision of either a licensed tech or have a doctor in the area, so that that would kind of not let you mail something.
That's not provided.
Where the service is being performed affirmatively. See, I think that paragraph kind of makes it so that you can't really mail it, right?
Like, could we?
And then we had talked about, well, what it also you could do is you could train them on the device in your office and then subsequently mail that same device to them because they had been trained under your supervision.
Right.
Yeah, but this is about the in-lab studies and not the home studies.
I don't think it differentiates.
I don't think it differentiates either, which is what's produced the confusion. I think if we differentiated, or maybe we just add at the end of this paragraph, home sleep test equipment may be mailed if oversight, if the study is read by and the patient follows up with a sleep physician, something like that. Just to clarify it.
Yeah, because there's three components to this. There's who can order a home test, how does it get provided, who interprets it, and then who follows up. And so we've got to figure out, we don't really want to regulate too much who orders it. I mean, anybody can order one, but then who actually trains the patient on the equipment? How do they physically get the equipment? Who does the interpretation? And then does somebody do
The next section, I think, where we require follow-up, that the patient gets the results.
Where is that? Is that right here or somewhere else?
No, it's down a little bit lower. It's another.
That was the other thing that we changed. We can add it there, probably. Maybe.
Yeah, that seems like that's the place to add it.
So that basically says that they have to be, licensed in Louisiana to do the interp
Well, I think it should say,
and then get
Does it-
follow-up.
yeah, you probably may want to say with a valid Louisiana license or telemedicine permit or whatever we call it. I think you want to make sure it's a qualified physician, but I don't think the difference of mailing it from Texas versus mailing it from, down the road means that the person who is monitoring and interpreting the study is not equally qualified. I don't see how that gets past protectionism.
What about something like home sleep testing equipment may be mailed to the patient in the event the study is interpreted by a board certified sleep physician and follow up with the patient is insured with a medical provider, something like that.
So add a D. That
What I'm
addresses,
thinking.
specifically addresses any questions that might come up with the home testing being shipped.
What do
Okay,
y'all
so
think about that?
I just want to let expectations set for y'all then. If we do that, we're starting this whole process all over. I mean, we obviously want to get it right and we want to do it only once, but we're going to have to send this back to the board for August and then back to the legislature, which is fine. It's just going to set us back a few months.
And if the alternative, what could we say without it having
Can
to
you
go
come
through
up a
that?
little bit?
Kind of what? I'm sorry.
Can you,
I'll go to the first bit of this, the mutual obligations.
and then now back to the next page?
I mean, we're not specifying and see that it's a board certified sleep physician, but we don't have to really, because that's the only people that are really interpreting them because of the CMS requirements.
If y'all don't think we need to add any words and we're not in direct opposition to the
I don't
rule.
see that we exclude anything.
I think it was in the other part that where we excluded it. That was where you have required direct supervision during setup. That's the part that's problematic, probably.
Go up a little bit from there. This is,
So we didn't really change this direct supervision to restrict anything further. We expanded it to not require the physician to be to limit that to just polysomnography. So now it's any physician that can do it. But the direct supervision requirement is maintained from the rules that are in place right now.
so I
So
guess
that's the definition of direct supervision. Are we requiring direct supervision for setup of home sleep tests? Does that come?
That's, I think, the question. Let me see if I can pull up the rules as they exist right now to see if that is there.
Because the problem isn't with the definition of direct supervision. The problem is, does that apply to home testing?
Right.
Well, I think if that was something you wanted to address because you had reports of people putting the machine on improperly, not getting proper instructions on how to use it, and then getting a bad study that had to be repeated. But again,
Right, because I believe that we had like a few conversations about this, that we didn't want people who weren't, qualified to just receive the test in the mail, put it on themselves without knowing what to do, and then, do the test wrong. So does the direct supervision?
See, that actually circles back to who's ordering the test. Whoever's ordering the test should be ensuring that the patient is competent enough to perform the home sleep testing. we're not really addressing that on any level.
No.
We're assuming that anybody that can order a test, any kind of provider that orders a test, is looking at the patient and saying, "Oh yeah, they could figure out how to do this." Okay. So, sometimes they're right, sometimes they're not. I don't know.
See.
I mean, I think our safeguard is that, you have to be a board certified sleep physician to do the interpretation because of the CMS requirements. And so if you would do the interp, you've got to be able to know that that patient got followed up and was told, look, it was a bad test. You didn't have the probes on or whatever, so I guess you're not going to be able to catch it up front. But if you get a bad test because the patient was incompetent at doing the testing, whoever did the interp should be board certified. And if they requires follow-up, but then there's the problem, do we really have to have board certified people following up a home test? Can we have mid-level provider? Well, that's not the term anymore, but nurse practitioners and other people that are following up with these patients. I guess we've got to be careful in our interpretations to say this was an inadequate study, needed to be repeated, or I don't know. This is not easy.
Well,
So
given
if
that,
y'all-
I
Go ahead.
apologize. Well, I
You
was
go
going to
ahead.
say that the backstop is that we're a complaint-driven agency. So presumably, if something went horribly wrong to the great expense of someone's patient or someone that they knew, it would violate the standard of care if they didn't ensure that the patient was properly educated and the test was being performed appropriately. So we could get a complaint and we could do something about it, but absent that complaint, we'll never know.
So it sounds kind of like we can, if I have a patient that lives 2 hours away, I can use Snap Diagnostics and have it mailed to them if I'm reading it and following them up, and we don't really have to make any changes. Is that what everybody's thinking?
I don't know. I kind of thought the way we had left it is that when the patient received the equipment, they had to be set up by somebody with direct supervision. I'm not sure exactly where that does that, but I thought that was the feeling that we were trying to go for, but now need to revise. So we have that definition of direct supervision, and then we have the actual testing must be done under direct supervision.
That's what I'm trying to find real quick. Let me look.
I think direct supervision is the Medicare definition.
Yeah, that's it right there. B, right? On column 2, number B, that's the
Yeah.
problematic area, right?
Yeah.
That's it.
So it says okay, well then it says this doesn't apply to someone who is under
Oh
the
no, this
direct
is somebody
supervision.
in training. So this is
Yeah.
yeah. So where is the part where the procedures need to be done under what kind of supervision? It needs to be done by a licensed, tech. And then what does the supervision have to be for testing in general? Where is that in there?
I'm not sure that it is. I'm trying to find it.
See, these are all the definitions. It must further someplace else. It must say
Not those words. It doesn't.
Yeah.
There was a question May 18th, 2018 about this. I don't know if y'all remember that. I pulled it up. And they asked if home sleep testing equipment had to be set up by a Louisiana licensed PSG technologist. And the answer was yes. This was back in 2018, and I think this may need to revise that. It doesn't necessarily have to be in the rule, but I don't know. I don't like this being out there if we're saying that we can mail it.
So, yeah, how do you ensure that the patient is properly instructed?
Seems like they need follow-up with a physician or with someone that ensures the test was good.
Yeah.
The follow-up seems like the most critical piece.
It really
So it
does.
also comes up in unauthorized practice or causes for disciplinary action. It says practicing polysomnographic technology other than on the written prescription or verbal order of a physician or under his direction or supervision or performing or attempting to perform, yada, yada, yada. But there's no like you have to. I think we were under the impression that there is a clear one, but now I think it just has that. It just the definition of direct supervision is there.
It
And so
does seem
that's
like you need a separate clause that starts in the case of, in the case when a sleep study is conducted at home, comma, et cetera, et cetera, et cetera. I mean, that is the fact. It's what, 1/4 of the cost to the patient, and you have the
Right.
morality issue and everything else. So it is a fact of what you practice.
but right now it doesn't seem like there's anything prohibiting you doing that. It just
The
says you
only-
have to follow up and you have to do it. So like there's nothing prohibiting you sending them. And the people that are in training, they're under the direct supervision.
Yeah.
And
So
the supervising person has to be present in the room.
So here's this letter. I know I keep bringing up the letter, but it says
Yeah, but
they asked this question. Chris Haar sent it in. Not unlike other
Yeah.
types of diagnostic testing, the law requires the devices, equipment, and patient instructions necessary to ensure proper PSG testing must be performed and given or applied in person by an
Yeah.
appropriately trained and licensed healthcare provider. So they said in person. Now, this is back in 2018. I mean, things have changed, but I wish it was more clear.
Well, that's why we went through this process, was because that letter was not enforceable.
Okay.
And so we wanted to come up with something that we could enforce.
Well, maybe the legislative guy reading this with fresh eyes brought up a good point that as far as how we use these phrases, direction and supervision of a physician, and then also direct supervision really kind of means the same thing. And we just use them differently, and why they're defined differently, I'm not sure. But if the only place in which we use direct supervision is really in the training session or, of someone who's learning, then it's kind of redundant.
I think we were partially wanted, if a patient came to your office and somebody in your office instructed them in the use of the home equipment, that coming under the supervision of the physician counted, so they didn't necessarily have to be licensed.
The person providing the home sleep testing equipment.
Right.
Right.
Yeah.
But I mean,
mean,
that's still all of this part,
Yeah.
That's the same thing. So like it doesn't need to be defined twice. We can put up, we can make it direction, supervision of physician, and then we could even add in there maybe a home sleep test does not need direct in person, or this does not apply to home sleep tests when there is adequate follow-up or
Well,
something.
actually, if you look under the definition of polysomnography, it says the performance of sleep diagnostics in any setting or location under the direction and supervision of a physician who has performed a comprehensive clinical evaluation. So that's the only place where we tie supervision or direct supervision or any kind of supervision to the actual testing is under the definition of polysomnography.
Yeah.
And that says any setting or location under the direction and supervision. But that requires a comprehensive clinical evaluation and based on the evaluation, ordered the test. So that would cover people like Kyle and I. We've seen the patient, we've done a comprehensive sleep workup, and now we're ordering this type of testing.
Can we then just delete this? I know that we kind of
Delete which?
direct supervision.
No, I think that's necessary for the training of technicians and stuff.
Yeah, you need direct supervision if you have a technician instead of a technologist.
But isn't that a direction and supervision of a physician who's responsible direction and control by a physician for the proper performance of polysomnography? Such direction and supervision shall not be construed to require physical presence of the supervising physician, provided that the physician is immediately available to furnish assistance and direction, either in person or by telephone. So like the way
that might cover you, Kyle.
Let's see.
But the direct supervision needs to stay in there, because if you have somebody that's in training, they need a licensed tech in the room when they're doing overnights. And so that's where that direct supervision definition comes in.
No, but if you go to the paragraph above, direction and supervision of a physician.
Or qualified healthcare provider currently licensed. So that would be the licensed technologist doing a sleep study overnight with somebody that's just a technician. So that's why we need there is a difference between the two. And one of them is, the licensed tech's got to be there if there's a tech that doesn't have their license yet.
So if you
says that it's just of a physician.
So if you send the home test and the patient has questions, that the physician's office would respond.
Yeah, it does say either by telephone or electronic means, so maybe that covers this.
Yeah.
Because it's throughout the performance of the procedure or service. So I think you're good. I think direct supervision is just used in the training session.
Whereas the out-of-state people, there's no way of getting help if you get something in the mail. They give you maybe a video to look at or a connection to a YouTube video.
So that we don't have to change anything on here. All we have to do, maybe go back and address the letter that went out before.
No, the letter that went out before I think is null and void, because there was no way of enforcing it.
Yeah, it seemed more like best practices and
that's why we're going through this whole process, is because that letter didn't work.
So basically we can just leave this as is.
I think we might be good this way.
Yeah.
That sounds good. Not trying to complicate things. It was confusing to me.
It was a good exercise. And now we don't have to change anything, and it could be in the August register.
Now we all know how to defend it when people ask us questions. So we're
Right.
Because he asked me those questions and I was like, I think this is what it means, but let me go. Luckily, we have a meeting on Friday, and he said just to make sure we circle back today with him. So,
And then we just make a note that when we announce the new rules, that we clarify that question, that answers that previously, is recalled, is no longer applicable.
right. Yeah, let's definitely take that down. Let's have, do we need a vote to approve it? Like, can we stamp this?
All in favor?
Move forward.
Of approving this?
Aye.
Aye.
Awesome. I'll email the guy now.
Judson and Joshua?
Yes, and I.
Okay. In favor, so next item is the sleep course.
Okay. So as you all may know or may remember, we did create a laws and rules course on CE Broker. It is up. And the newsletter that just went out at 8:25 this morning mentions that the course is available. And mentions, with, again, just to refresh everyone, all licensees right now, except at this point, perfusionists and clinical exercise physiologists are required to take a laws and rules course before they renew for the first time. And these courses are available, on an annual basis for anyone who just wants a few hours of board approved CE or CME. Just to refresh, themselves about the rules, or perhaps they never really looked at the rules. And in many cases, when someone has a board action, part of their consent order is actually to refresh their knowledge of the rules, whoever they're, whatever profession they are in. So that's what, these rules courses have been up for a while. The Polysom course is now up. My two guinea pigs have taken it. That is to say, Dr. Bordelon and Kylie Foster, who worked with me on it. There have been two other, even though we haven't announced it until this morning, two other people have apparently taken it. I just went on CE Broker while we were talking just now.
I took it this morning.
Oh, that was you. Okay, great. Well, thank you.
Yeah.
So I got your email and I
Yeah.
took the course. I got one
Yeah.
wrong.
Okay. So one of the things, so a couple of things, I would heartily encourage those of you who have not yet taken it, if you would, to take it. And if you have any questions or suggestions or thoughts, to individually email me. I'm always very mindful, as Patricia Wilton reminds us, about the open meetings laws. So any suggestions or questions you have sort of have to come to me directly to address, as opposed to the group, unless it is in the context of a meeting like this. But if you see something, or you see a typo or whatever, but I would hugely encourage you, and I will send an email to that effect later, those of you who have not yet taken it, to take it, because I would prefer to get any little inputs now and change it just to keep the version numbers under control. Because I can go in and make a change almost instantaneously, but I don't want to make a change and then another change and then another change. I'd love to get your comments and just anything. If there's just some little error you see, that's one thing. But the other thing I wanted to address, because this came up also, I guess the last meeting, and Patricia commented on this. One of the things that we can target towards, the October newsletter, as we discussed, is to have an advisory committee corner discussion from you all specific to polysomnography. And if in that newsletter, they're out quarterly, obviously we can send email blasts about this, but we can also always put these things, in some kind of advisory committee discussion in the newsletter. So if you want to, if we want to do something for October saying, we're in this rulemaking process, it's been, we can just at that point say where it is in the process. Maybe it will have just been approved by that point. But and in addition to the fact that there's this course up, some of the things that were not appropriate for the course, but we want to discuss, are A, B, and C. And we could certainly, in addition to writing the rules course, I'm the one who writes the newsletter. So I'm happy to work with any of you to get that done as well. Because you may recall when we were talking before, there were things that got brought up during the course discussion where I was like, that isn't technically a rule, but it's a question of good practice. It isn't literally in the rules, so I can't create a test question about it, which doesn't mean it's not important to say to your constituency. So if somebody wants, I don't know who among you wants to maybe work with me over the next couple of months to write up that advisory committee corner from the polysomnographers, I would welcome the help.
Yeah, I think when Colleen and I were going through, there was, I think, two questions where we differed. And one, I guess, with pediatrics, you have parents are required to be there with the child, whereas the night studies with adults, you may be there, the tech may be alone with the patient. And the questions were whether the tech should help the patient to the bathroom or to change positions, those kind of things.
And also the question came up about medications, about assisting a patient with their meds. That also came up.
Yeah. Yeah, I think most labs don't have, the option for, sedatives, and that was, I think there was a discussion in the blog about that. And what we did was we would give if somebody requested it ahead of time, we would give them just a prescription for a few, Zolpidem, but, I think some labs may the text giving it out, and it's out of their, expertise, so it's kind of a touchy area.
That's come up in some labs using Afrin for titrations too.
Yeah,
We don't, but I've heard that before.
yeah,
Well, one of the things that kept coming up in my discussions with Dr. Bordon and Kali is that there is a variability in labs, and that between those issues, and I think we also had some security related issues, just sort of stressing to everyone who might be reading this, that there are variations and you have to check with the policy of your particular employer, I guess, or your
Yeah.
particular institution. So as I said, I think it's worth writing a little thing about this. And then present, as Patricia Wilton suggested, presenting that in the newsletter. You're just a discussion of issues, not specifically rules.
I think that would be helpful even for the physicians that are the medical directors, because I know we've had those discussions too. What's appropriate security? Can you run a single female tech in a facility with 2 male patients? What do you have for security? And those policies probably should be discussed on some level by medical directors, and the comfort with techs, and how are we ensuring security? They're all really good topics.
Yeah, well, would like to work with me, and I don't know who else, to just sort of get this written up?
Sure, I would love to do that.
Okay, appreciate it. Thank you.
Next item is, patient educator. I'm not sure that there's anything new to bring up here.
We had kind of left it that there weren't that many out there, and we didn't need to address it at this point. Is that how kind of we left it?
I think so.
Yeah. Okay, and then the fourth item is membership changes, as mentioned. Kylie requested to resign or send in a letter of resignation. And then Melissa Butte has been irregular in attendance, so we might actually want to try to replace 2 positions.
Yeah, I texted Melissa just a few minutes ago and I never got a response.
Yeah.
So they have to be recommended by LASM. So if I had some candidates, I would contact the LASM and see if they would be willing to put them up as candidates.
Yeah.
I can do that.
Because I think it'd be nice to have people from a bunch of different sources, like a hospital-based lab, and then some of the business labs, and so that there's kind of broad representation.
Yeah.
Yeah, I think you're right. If there's a certain place that we would refer someone to put their name in the hat, for example, Thibodeau Regional has a tech that I was talking with yesterday, just not about this, but she might be a good person.
Well, Joshua, I think you have the most contact with LASM.
Yeah, I'm director at large. We gotta. Yeah, I can talk to anybody. Whatever you want. Whatever you want me to tell them, I can tell them. Every lay it.
Yeah.
So Joshua, I may email you a couple possible candidates that you could look at that are members of LASM, maybe.
Yes, ma'am.
And then for them to send the list to Dr. Plata, and 3 names for they'd need 6 names, or?
Well, they like 3 names for each nomination. Again,
They can overlap?
you said them 5 for 2. I mean, they might take it. I just know that they will never reject 3 for each. I'll
Okay,
set up anything you tell me, and if they reject it, they reject it.
yeah.
Okay.
Okay,
Well, like we said, they already had two in mind. So send me what y'all have, and then hopefully we can get the fix in that regard, and we'll settle.
So I need names and CVs.
Yes, sir.
And I guess as a matter of courtesy, Dr. Collada, you might want to try to have Jacinta set up some kind of conference for you with Melissa to ensure that she is not upset about being replaced.
I'll be happy to do that. Jacinta, if you're on, make sure you set that up for me.
yeah.
I will take care of it.
Anything else? Any old business, new business? Other comments? Discussion for our next meeting. September, October? What? When will the
The LASM stays like October. Take it to I'm telling you about the annual meeting.
I think he was talking about the annual meeting for the LASM is in October, right?
Straightforward, yeah.
Does anybody imagine there's going to be any issues if by the end of the year Zepbound gets a FDA approval for sleep apnea? That probably is not going to apply to anything that we do here on the board, right? As far as prescribing these agents through sleep clinics or sleep labs, or
I'm sorry, I didn't quite get the question.
I don't think there's going to be any repercussions about the fact that one of the new weight reduction injections is probably going to it's going on fast track through the FDA right now for treatment of sleep apnea, but that would be under that probably wouldn't impact us, right?
Well, if y'all
we have to say about
it. Do you all treat sleep apnea, and would any of your doctors want to improve their income by doing such?
Well, we're looking at it now. That's why I'm kind of asking it, but I don't think it would impact anything on the board that I can think of. But I was just throwing it out there for people to think about.
Yeah, I think that would mostly apply to your office work and not necessarily the sleep lab.
That's what I was thinking. It's really a physician clinical, thing, not anything that would come before the board.
There's a lot of stuff popping up about this whole semaglutide treatment for all the different things and how they're getting it, and is it compounded, is it brand name, and all these things. So we're still ironing out our recommendations right now, if you want to know the truth.
Yeah, it's going to be interesting because I think Eli Lilly is going to get indication by the end of the year, and so it's my staff is all training up to find out about how do we address this? Do we prescribe? Do we not? Do we recommend? I don't know. It's a big unknown.
My question to you is does it actually alter sleep apnea, or is it because of the weight loss that the sleep apnea goes away?
It's because of the weight loss.
Okay. So that it only works for obstructive sleep apnea and not central sleep apnea.
Yeah.
Correct.
Correct. Okay. Discussion for the next meeting. October or September. Any ideas? Do we have anything that we need to discuss?
We could probably do October since we don't have anything on the horizon pressing.
Okay.
We might want to also just wait to see when everything gets published, because that's going to start some timelines, we'll be able to get like public comments in and all that with the rule promulgation. So once that happens, why don't we see if because maybe we can hit two birds with one stone. I don't know.
There may be people that want to comment to the advisory committee. There may be people that want to comment to the board itself. Y'all might want to know about it and make your recommendations as well about anything that is determined by the public to be controversial. And the longer you put off the meeting, the longer it takes to do things.
So we can see if it gets published next month and then try to find a date.
Yeah, I think for the benefit of everybody, that would be the best. Because if you don't want to weigh in on anything, that's fine. We just leave it alone. The board will make the decisions, but if you want to weigh in, you're going to have a meeting.
Can we just wait and see and you contact us if it looks like there's a lot of stuff coming up?
Happy to do that too.
Okay.
It's often hard to get a meeting together like that because people's schedules in advance and that kind of stuff. That's what we'd like to give them a little lead time.
So you're thinking schedule one for September just in case we need?
Schedule
October.
for the end of September.
End of September, okay.
And then we can always move it if, we need to.
We can cancel it if we need to. That's fine.
Fridays are always good for me.
Yeah, the Friday seems to work for us well.
Yeah.
Well, Miss Jacinta will look at the schedule and make the date and send it out to y'all very shortly.
And maybe Dr.
Indeed.
Davis, you and I can work on that piece and have something to present, for people to comment on during the meeting.
That would be great. I'm not quite sure what the format is, so just kind of send me a little blurb on how you want that formatted.
Sure, sure.
How about the 27th of September?
Works for me.
Good for
Dr. Van is available on that date as well.
I want to tentatively put that down.
That week. September. So our board meeting will be over by that time. We're in good shape.
Okay.
Cool. Good work, everyone.
Thank you very much. Appreciate
Thank
it.
you.
Thank you all.
Thanks.
Have a good weekend.
Bye-bye.